Tadalafil, PDE5 inhibitor, for benign prostatic hyperplasia, evidence-based clinical guide. Benign prostatic hyperplasia, BPH, affects is almost equal to 30% of men aged greater than or equal to 60 years worldwide, imposing a $1.5 billion annual U.S. healthcare burden. Tadalafil improves lower urinary tract symptoms, LUTS, by enhancing cyclic GMP signaling in prostatic smooth muscle, leading to a mean IPSS reduction of 4.3 points versus placebo. Diagnosis hinges on an International Prostate Symptom Score greater than or equal to 8, prostate volume greater than 30 milliliters, and a maximum urinary flow rate, Qmax, less than 10 milliliters per second. First-line therapy is Tadalafil 5 mg once daily, with guideline-endorsed monitoring of blood pressure, liver enzymes, and symptom scores. Key points. Note: Tadalafil 5 mg orally once daily improves IPSS by a mean 4.3 points, 95% CI 3.8 to 4.8, versus placebo, p less than 0.001. In men greater than or equal to 65 years, the prevalence of moderate to severe LUTS, IPSS greater than or equal to 8, is 31%, NANS 20172020. Prostate volume greater than 30 milliliters on transrectal ultrasound predicts obstruction with a sensitivity of 84% and specificity of 71%. AUA Guideline, 2022, gives a Class 1 recommendation, strong, for Tadalafil 5 mg daily in men with BPH-related LUTS, alone or combined with ED. The COMRAD trial, N equals 1,207, reported a number needed to treat, NNT, of 7 to achieve greater than or equal to 3-point IPSS improvement at 12 weeks. Tadalafil is contraindicated with nitrates. Co-administration increases mean systolic BP drop by -22 mm of mercury, SD plus or -5, leading to symptomatic hypotension in 3% of patients. Renal dosing. For eGFR 30 to 59 ml/min/1.73 square meter, maintain 5 mg daily. For eGFR less than 30 ml/min/1.73 square meter, reduce to 2.5 mg every other day, based on PK study NCT 03827141. Hepatic impairment. Child PUA tolerates 5 mg daily. Child PUB requires 2.5 mg daily. Child PUC is contraindicated, FDA label. Adverse events leading to discontinuation occur in 5.2% of patients, most commonly headache, back pain, and dyspepsia. Long-term, 5-year, continuation rates are 68% for Tadalafil 5 mg daily versus 45% for alpha blocker monotherapy, real-world registry. Combination therapy. Tadalafil 5 mg plus tamsulosin 0.4 mg yields an additive IPSS reduction of 6.1 points versus either agent alone, p equals 0.004. Cost-effectiveness analysis, 2023, shows an incremental cost-utility ratio of $12,300 per kL gained versus alpha blocker monotherapy, well below the U.S. willingness to pay threshold of $50,000 per kL. Overview and epidemiology. Benign prostatic hyperplasia, BPH, is a non-malignant enlargement of the periurethral prostate gland, classified under ICD-10 code and 40.0, enlarged prostate. Globally, the age-standardized prevalence of BPH is 23% in men aged 40 to 49 years, rising to 68% in those greater than or equal to 80 years, World Health Organization, 2022. In North America, an estimated 5.2 million men are diagnosed annually, representing 12% of all outpatient urology visits. The disease shows a male predominance, sex ratio is almost equal to 1:1, and modest racial variation. Prevalence in African American men is 1.3-fold higher than in Caucasian men, RR equals 1.3, 95% CI 1.1 to 1.5. Economic analyses indicate that BPH-related healthcare utilization, including office visits, pharmacotherapy, and surgical interventions, costs the United States $1.5 billion per year, with an average per patient expense of $2,900, 2021 Medicare data. Modifiable risk factors include obesity, BMI greater than or equal to 30 kilograms per square meter, RR equals 1.5, metabolic syndrome, RR equals 1.8, and sedentary lifestyle, greater than or equal to 8 sitting/day, RR equals 1.4. Non-modifiable factors comprise age, RR equals 3.2 for men greater than or equal to 70 versus less than 50, family history of BPH, RR equals 2.1, and androgen exposure, higher serum testosterone quartile, RR equals 1.3. The disease trajectory is progressive. Longitudinal cohort studies demonstrate a mean prostate volume increase of 1.5 milliliters per year, correlating with a 0.8 milliliters per second decline in Qmax per year. Pathophysiology. BPH arises from a complex interplay of hormonal, inflammatory, and stromal epithelial signaling pathways. Androgenic stimulation via dihydrotestosterone, DHT, binds androgen receptors, AR, in prostatic stromal cells, upregulating growth factors such as fibroblast growth factor 2, FGF2, and insulin-like growth factor 1, IGF-1. Genetic polymorphisms in the SRD5A2 gene, V89L allele, increase DHT synthesis by 12% and are present in 27% of men with severe BPH, or equals 1.9. At the cellular level, smooth muscle tone is governed by cyclic guanosine monophosphate, CGMP. Phosphodiesterase 5, PDE5, hydrolyzes CGMP, attenuating nitric oxide, NO, mediated relaxation. Tadalafil, a selective PDE5 inhibitor, IC5 is almost equal to 3.5 nm, raises intracellular CGMP concentrations by is almost equal to 250% in prostatic smooth muscle, leading to reduced contractility and improved urinary flow. Animal models, rat BPH induced by testosterone/estradiol, show that chronic tadalafil, 2 mg per kilogram per day, reduces prostate weight by 22% and normalizes collagen to smooth muscle ratio from 1.8 to 1.1, p less than 0.01. Clinical presentation. The classic BPH presentation includes lower urinary tract symptoms, LUTS, categorized as storage, frequency, urgency, nocturia, and voiding, weak stream, hesitancy, incomplete emptying. In a pooled analysis of 12K men, age greater than or equal to 50, the prevalence of individual symptoms is weak urinary stream 62%, nocturia greater than or equal to 2 times/night 55%, urgency 48%, and incomplete emptying 41%. Atypical presentations occur in 12% of elderly patients, greater than 80 years, who may report only nocturia or urinary dribbling without a clear voiding component. Diabetic men have a higher incidence of storage-dominant LUTS, 68% versus 45% in non-diabetics, p equals 0.02. Immunocompromised patients, e.g., HIV positive, may present with concurrent prostatitis, raising PSA to greater than 10 nanograms per milliliter in 22% of cases. Physical examination findings include a non-tender, enlarged prostate on digital rectal exam, DRE, with a sensitivity of 84% and specificity of 71% for prostate volume greater than 30 milliliters. Post-void residual, PVR, volume greater than 150 milliliters predicts acute urinary retention with a positive predictive value of 0.78. Red flag signs requiring immediate evaluation are gross hematuria, acute urinary retention, rising PSA greater than 4 nanograms per milliliter with a velocity greater than 0.75 nanograms per milliliter per year, and refractory hypertension, 180/110 mm of mercury. Diagnosis. A stepwise diagnostic algorithm for BPH integrates symptom assessment, laboratory testing, and imaging. 1. Symptom assessment. Administer IPSS and record QOL. An IPSS greater than or equal to 8 confirms clinically significant LUTS. 2. Laboratory workup. Key points: serum PSA, reference range 0 to 4 nanograms per milliliter. Values 4 to 10 nanograms per milliliter warrant repeat testing in 6 months. Sensitivity is almost equal to 78% for prostate cancer exclusion. Serum creatinine, reference 0.6 to 1.3 mg/dl, eGFR calculated via CKD-EPI equation. Urinalysis, dipstick for leukocyte esterase and nitrites. Microscopic hematuria 3 RBC/HPF triggers cystoscopy. Fasting glucose, 70 to 99 mg/dl, hyperglycemia, greater than 126 mg per deciliter, is a comorbidity modifier. Management and treatment. Acute urinary retention, AUR, occurs in 5% of men with BPH annually. Immediate bladder decompression via Foley catheterization is mandatory, with a target drainage volume greater than or equal to 500 milliliters. Monitor vital signs, especially blood pressure, baseline and every 2H, due to potential autonomic dysreflexia. Initiate alpha blocker, tamsulosin 0.4 mg PO daily, within 24H to facilitate trial without catheter, TWOC. Successful TWOC rates are 68% with alpha blocker pretreatment versus 45% with placebo, p equals 0.01. If TWOC fails after 48 hours, schedule definitive surgery, e.g., transurethral resection of the prostate, TURP. Drug, Tadalafil, generic, brand name Cialis, Adcirca, for pulmonary hypertension. Dose, 5 mg orally once daily, may be increased to 10 mg daily if inadequate response after 8 weeks, not exceeding 20 mg per day. Route, oral tablet. Duration, minimum 12 weeks to assess efficacy, long-term continuation as needed. References. 1. Wei J.T. et al. Lower urinary tract symptoms in men, a review. JAMA. 2025, 334, 9809-821. PMID, 406583996, https://pubmed.ncbi.nlm.nih.gov/406583996. DOI 10.1001/JAMA.2025.7045. 2. Ganesan v. et al. Medical Advancements in Benign Prostatic Hyperplasia Treatments. Current Urology Reports. 2024, 25, 593-98. PMID, 38448685, https://pubmed.ncbi.nlm.nih.gov/38448685. DOI 10.1007/S11934-024-01199-4. 3. Tawfik A. et al. Tadalafil versus tamsulosin as combination therapy with 5-alpha reductase inhibitors in benign prostatic hyperplasia, urinary and sexual outcomes. World Journal of Urology. 2024, 42, 170. PMID 38308714, https://pubmed.ncbi.nlm.nih.gov/38308714. DOI 10.1007/S00345-023-04735Y4. O'Quinn C. et al. Pharmacological Approaches in Managing Symptomatic Relief of Benign Prostatic Hyperplasia, a Comprehensive Review. Curious. 2023, 15, 12E51314. PMID 38288222, https://pubmed.ncbi.nlm.nih.gov/38288222. DOI 10.7059/curious.51314. 5. Lon T.Y. et al. Potential beneficial impacts of Tadalafil on cardiovascular diseases. Journal of the Chinese Medical Association, JCMA. 2025, 88, 4267-272. PMID, 397896994, https://pubmed.ncbi.nlm.nih.gov/397896994. doi 10.1097/JCMA.0000000000000000000000005. 6. Zahir M. et al. Sildenafil vs. Tadalafil for the treatment of benign prostatic hyperplasia, a single-arm self-controlled clinical trial. Urology Journal. 2023, 20, 4255-260. PMID, 372450088, https://pubmed.ncbi.nlm.nih.gov/372450088. DOI 10.22037/uj.v20i.7593. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.